Hi, my name is Stacey Rentschler from Washington University, and I'm the chair of the Outstanding Early Career Investigator Award at BCVS. And I'm very excited to be joined today by Dr. Jesus Jimenez, also from Washington University School of Medicine. Dr. Jimenez was selected as the winner of the Outstanding Early Career Award, and he's a rising star in our field. Dr. Jimenez, can you tell us a little about your background?
Yeah, so I'm a cardio oncologist by training, but I did all of my training at Barnes-Jewish Hospital, Washington University, residency fellowship, and then I did additional training in cardio oncology. After that time, I transitioned to my postdoctoral work, which is the premise of the talk and now the award.
Great, great. Very exciting. So can you tell us how you got interested in this field of cardio-oncology?
Yeah, so as a fellow, we rotate through the cardio oncology service, and it was one of those times where I was taking care of a patient who had melanoma, and she got treated with immune checkpoint inhibitor, specifically a PD-1 inhibitor, which is a therapy that essentially activates the immune system to fight cancer. Cancer, as we know, can find ways to evade the immune system, and so immunotherapy in this case was going to reactivate that immune system to take care of the cancer. But as it turns out, with such therapies, we found that it can have adverse cardiac events, meaning that the immune system can start targeting its own organs, including the heart. Myocarditis is particularly alarming because it can be fatal in up to 50% of patients. And so this particular woman got treated with immune checkpoint inhibitors and developed myocarditis. Luckily for her, we were able to recognize it early, got treated with steroids, which is kind of like the first line treatment, but we have since found that when it's fulminant myocarditis, you need stronger agents, and that's part of what the work is trying to uncover is the signaling mechanisms of such a robust inflammatory response from this treatment.
Yeah, that's very interesting. There's a lot of promise for these new drugs. Specifically, the one that's the focus of your work, can you tell us a little bit about where that's at in treating patients?
So CD40 agonist antibodies was the focus of my work. And the reason I got interested in CD40 agonists is due to its unique signaling. So basically, CD40 is expressed in antigen-presenting cells such as macrophages, dendritic cells, and B cells, and its ligand is on T cells. It's just a little bit different than conventional immune checkpoint blockades where the reverse is in order. And CD40 agonist, as it turns out, aside from its unique signaling capabilities, it's able to elicit anti-tumor responses even in those patients who have been resistant to the conventional immune checkpoint blockades, such as PD-1 inhibitors, CTLA inhibitors, CTLA-4 inhibitors, as well as PD-L1. And so what's interesting about CD40 is that we just don't understand how, since it's an emerging regulator of immune checkpoints, we don't know yet what's the impact is going to be on the heart, and that's what the work is focused on.
That's really exciting. So a lot of promise for treating cancer. And, can you tell us a little bit about then what you found can happen in the heart in some of this?
Yeah, so CD40 agonist antibodies, essentially we have uncovered that they activate CCR2 macrophages, which are an inflammatory macrophage that activates CD8 T cells, as it turns out, which produces interferon gamma. And so we found that since CCR2 is a primary target of interferon gamma signaling, that upon activation of CCR2 macrophages, you can elicit this feed-forward loop of activation to CD8 T cells, which then keeps making more interferon gamma and so on and so forth. As it turns out, this is mediated through IL-12 and TNF, some of the things, the other inflammatory cytokines that we uncovered. And we also learned that we can actually interrupt or disrupt interferon gamma signaling by interrupting the way, disrupting CD40 signaling within the CCR2 macrophages, or disrupting interferon gamma signaling receptors in CCR2 macrophages, such that we can actually abrogate that response of a robust inflammatory response. We also found that we can use neutralizing antibodies in interferon, specifically through neutralizing interferon gamma, as well as interrupting the signaling by using neutralizing antibodies of IL-12 and TNF. And finally, we've found that we can also interrupt that mechanism by depleting CD8 T cells. Now, that was the mechanism of how we think CD40 engages CCR2 macrophages to activate CD8 T cells. We took it a little bit step further because, as it turns out, CD40 is not classically been shown to result in myocarditis. We do see a spectrum clinically as well. We actually see the overt fulminant myocarditis where a person can basically die from it, but we also are seeing a lot more patients as we recognize this syndrome. That there is just a high inflammatory response, and that's what this work also highlights. And so we took it a step further by generating two cardiac injury models that basically show that if you are getting treatment with CD40 agonists, you're going to make those cardiac injuries worse, meaning that you can get worsened fibrosis, a worsen or increased infarct size that results in reduced cardiac function. And so it's just very exciting work that took a long time.
Yes, but you did a fantastic job, and it's very important for patients. A lot of oncology patients. You're doing a very important work to, further the safety of these very important drugs used to treat cancer. So, congratulations for that. Where do you see this going next?
Yeah, so one of the really cool parts about this whole work is that I was able to learn so many new techniques as I transitioned from primarily clinical work to my postdoctoral work, and now being able to incorporate both, I can really start thinking about the bigger picture. And that bigger picture is taking what the techniques, the approach, the signaling mechanisms, and taking it into a tumor model. So that's really the next phase of the work, and what my research program is moving towards. And that means that really capturing what we see clinically, right? I take care of patients with cancer who have had effects to their heart, cardiotoxicity, and immunotherapy results in cardiac toxicity in some patients. And so I want to understand that mechanism. As the field is moving from, as it's finding these emerging regulators of immune checkpoints, we're also, the field's also moving to combining these therapies, because there are those cancers that are just resistant to the conventional, even the combination. Now we're combining the emerging with the conventional. We're combining it with chemotherapy, radiation, and so forth. And that's really at the crux of what I'm going to transition to.
Great. It'll be so exciting to see how this, translates into the anti-tumor positive effects, balance with the possible toxicities. And so what a great field, place to be, studying. And congratulations to you, a rising star in the field. And we look forward to many more, future outstanding seminars and publications and awards for you in your career. So.
Thank you so much. It's very kind. And I'll give, of course, I'd like to always say thank you to all the support, including Stacey, who has been a direct mentor. It just happens to be that we're both at the same, doing this at the same time, happening at the same time as, of course, Corey Levine, who is my current primary mentor, and previous mentor is Jill Tardif, as well as my family, who has been supporting me through all of this.
Wonderful. Congratulations.
Thank you.